in the face of the analysis, but I can tell you one thing about the techniques that we're using in trying to work with this data, especially when it's huge and it's linked. A quick background and motivation for why we're doing this. Then I'll speak a little bit about current projects. Focus on the type of learning, which is type of technique used for analysing observational data in particular, but it's also useful for trial data. So I've done a previous analysis across the different projects back in 2017, and we wanted, so if you look in the population, you always have these mortality curves all over the world where boys have slightly higher mortality than girls, and that's normal to accept. So we wanted to look at the reason for the UK gap as much as and the way to look at it efficiently was to take intensive care mortality, because you have a higher population with a higher rate of mortality. So we did that, and we focused on infants at the time because we didn't want age variation to influence the result as an initial analysis. And we had 71,000 children. So we got a similar curve. So we had from 2005 to 2015, 11 years of data. The only difference was that the mortality reversed, how it's females that have higher mortality than men. And at the time, it took me 2 years to get to terms with it before I decided to publish it in case it was stupid. And then turns out that it was later. And we couldn't explain it with the variables that came with the PICU data set. So the PICU data set is a research database that collects data from all over the UK on paediatric intensive care practice. And none of those things explained it. The other thing that we observed is that 6% of admissions were boys, 40% were girls. More boys go in, and then more girls die in there, fortunately. The next thing we did was look at if this was driven by 1 or 2 units having such severe mortality for girls that it was dragging the entire thing to one side. But it wasn't. So these dots are all 35 units across the UK. That's the overall mortality showing males have lower mortality. And you can see most of the units right this way. So it's not 1 or 2 units that's dragging all this result, it's the majority of them. And we adjusted for the paediatric index of mortality, which measures disease severity on admission, but it's only on admission. So it becomes less relevant as you go through. And then we wanted to see what happens across the world. So has anyone else noticed? We did this last picture of you. And the data shows that it's not very clear because a lot of the numbers are very prevalent in the news when we did a sample size analysis and at least 80,000 to show it. And also the populations are variable. But here we picked 4 studies that then focused on the whole population, and then they didn't select subpopulations, so sexes. And that's still quite a trend. And when you combine the results, because you give more weight to larger studies, you still get higher mortality for females. So it's 11% higher alteration. And again, we couldn't explain it, which gave us the motivation to look at this data, but expanded it out to be beyond intensive care. So we wanted to look at hospital admissions and see if there are anything that can explain this reversal of mortality, and then look at maternal practice. So we wanted to make sure that this is not a paradox, and you have an association that we've seen. It's counterintuitive to the population trends, but we can't do a randomized study, obviously. But we've seen similar observations in other countries. And just to explain the reason behind this, why do I think it could potentially be a paradox? It's because we've observed similar paradoxes in other studies. So if we look at the whole population, we have sex having differential death rates, so males and females have different death rates, and then that's just points here. And then you have X, which is a group of factors. So sex can influence this group of factors. So for example, it can influence disease severity, age, weight, weight, health indicators, and so on. But if we look at just the PICU population, this will slightly change in that we're going to have sex driving admissions to PICU for males and females. And then these factors, the number of factors, are going to have an influence on driving children into PICU, but also an influence on deaths. And by design, we're going to only select PICU children. And that means that we have selected a subpopulation from the overall population. And now we will induce an association that potentially wasn't as strong in the first place when it didn't exist. And this biased association has been described previously. How do I show you this? Oh, I see. So this is being explained in something called the obesity paradox. I don't know if you've heard of it. So obese patients going into adult intensive care have better survival than non-obese patients. And there's been several attempts of trying to explain this. But recently in 2020, someone finally did a type of analysis, which I'm going to speak about, and show that this is actually a paradox driven by the subselection of a population, a particular population, and not a true effect. Okay. So the design of the current study was that now we know we need a bit more variables. So I've picked it again, but this time linked it to maternity and HES, linked it to maternity and baby health, and also linked it to ONS mortality. So this will give me all the children between 0 and 18 years. So this time I'm not focusing on neonates, on infants, data for all their mothers, data for all their admissions, and up to 5 years of mortality records. And the reason we want this is because a lot of the mortality is factors that we cannot get from the intensive care data. So it's maternal, neonatal, and addition to these factors which can be explained in the HES reports that we don't have. So the next thing was to look at the relationship between these graphs. And I'm not going to dwell on this, but this is one type of causal graph that you could do, and it's taken me nearly 3 years to actually come up with a good sort of reasonable expectation of how these variables relate to each other. And this is just one stage of it. But it's just to show that the analysis begins with looking at the associations between these variables objectively and from a subject matter knowledge point of view and from an expertise point of view. There's nothing to do with actual mathematics or analysis. And then that leads me also to targeted learning. So what is targeted learning? Well, we define the causal question, which I have in this case, and I want to know the difference in death rates between male and female. And that's my target. It's either the risk ratio or the risk difference. And then I want to define the causal estimate. So the causal estimate is the actual risk difference or the risk ratio. And then study the causal graphs, and then I want to target my analysis to the target estimate. And the reason why this might seem a little bit obvious, but when you look at really large data sets, people get lost in where exactly is the optimization happening, especially when you try to use machine learning. So one of the things that targeted learning allows us to do is, because we have very large models and very large data sets, allows us to utilize machine learning so it can help us with the analysis. And one of the things it allows us to do is that rather than assume something is normally distributed when it's actually not normally distributed, so we end up with a lot of bias from the empirical distribution versus what we impose on the data. Targeted learning allows us to use the empirical distribution, so we don't assume any distribution. So we remove that little bit of bias that we're actually creating from imposing this on the data. And also, it helps us use large numbers of variables, because having linked all those records together, I have nearly 200 variables, and how do I know which variables are going to go into this analysis? And as I've shown before, sometimes you can put variables into the analysis and it can cause a bias. So it needs to have careful selection of why you're doing this and how you're putting it in the So in summary, we start with the causal analysis, then we move on after we've decided what's going into your model. You employ machine learning simply to help you decide on, estimate some parameters along the way, which these parameters then you will put into the machinery of targeted learning that we will get into. The other thing that it allows you to do is, by targeting the parameter, which is the causal parameter of interest, it allows you to combine several machine learning algorithms in one big superlearner and then target it towards this causal question. Whereas before we used to have separated causal analysis and machine learning as two different things. Traditionally, machine learning has always been used for prediction, but we're not using it for prediction anymore. We're actually using it to help us estimate and make sense of the large data sets that we have, and then plugging that into a causal question. So it allows us to stack a number of algorithms, put them together, and then direct those towards a causal question. The other thing it allows us to do is, the same way with prediction, it allows us to use sample splitting and cross-validation. Some people call that double machine learning, just splitting the sample. And by doing this, we can remove some of that bias. And in particular, that bias that I spoke about when we select subpopulations or we use the wrong distribution. And that will hopefully prevent us from having a situation where our predictive model is actually only predicting itself and not predicting anything else. So in summary, targeted learning really is all about deciding on a methodology that starts with the causal question and then move on to employ machine learning to address a causal analysis. The other thing that we tend to overlook is that the use of machine learning without a causal framework is actually fraught with danger, because what machine learning does is simply a signal detection system. And without any training or without any human input, you can detect anything and it could be meaningless. So applying a causal framework first is important in order that machine learning can help address the question. And TME is that complete framework where it starts from the causal question towards which parameters you're going to address, and then eventually answering hopefully, and then moving bias. Thank you.